When I first heard about the Stellest lens, I thought it was a gimmick. I thought there's no way this thing's gonna work. But I was wrong. And if your kid's nearsighted, that matters. Now, most experts think that by 2050, we'll have roughly 5 billion people that are nearsighted. And so nearsightedness just means that the eye is too long to begin with, based off the curvature of the cornea. And so as we get older, the eye's gonna naturally get a little bit longer. And that's where myopia progresses or nearsightedness gets worse. Now, someone that is a -1 maybe at 7 years old is projected to be about a -6 at 18 years old. And really, we can hedge off and stave off a lot of diseases if we will keep that nearsightedness, that minus power, at a lower than 3 number. If that number is above 3, we have about a 12 times more likely scenario of a retinal detachment. And we're about 3 times more likely to end up with glaucoma. And so keeping that power low isn't just about trying to keep us from having thick glasses. It's about mitigating and stopping some diseases. And what research tells us for sure is that the earlier that kid can get that intervention, the more we can slow down that progression, the less likely they are. So the earlier we can start, the younger that patient is with this myopia type treatment, the better off the results are and the better the outcome is for the kid and for the patient. So what exactly is the Stellest lens? So it was designed by EssilorLuxottica, a large frame and lens manufacturing company in the world. And it was designed with the myopia management in mind. And so basically what they're doing is what's called the HALT technology. Is you've got the clear center vision of that lens, and then you have these rings that kind of look like almost like solar systems going out around that lens. And there's all these little dots, these little lenslets along that solar system section. So it looks like almost like planets orbiting the sun. And so those little lenslets, the concept there is they're going to create some defocusing out on the retina, and that's going to give the brain and the eye a signal that we shouldn't grow, we shouldn't get longer. So traditional glasses only correct the center part of that vision. Then as we get away from that center part, we actually have to adjust the curvature of those lenses so that they fit into the frame more so than we have to do for clarity. And so that creates some weird focusing out on the side, and where there's this whole defocusing periphery theory that what'll happen is if we're getting improper focusing, if it's too long out there on the wavelengths of light out on the peripheral retina, then it's stimulating the brain and giving receptors and giving signals to the body that needs to get that eye and make it longer. Now, don't hear from me that glasses are making things worse, because they're not. Research done in 2022 showed that it's not just a glasses thing, that people are progressing and getting worse, and they get even worse if they don't wear the glasses. And so it's one of those deals that the glasses, yes, they're not helping out, but they're also not the problem there. And so the concept here behind these lenslets is that it's going to stop that theory from being a problem. And research has shown that it actually does work. And so those lenses create myopic defocus, and that's how it gives that signal to slow that growth. So how well did this lens actually work? Actually really stinking well. So about 71% of reduction of nearsightedness is what the research shows over a 3-year time frame of wearing those glasses. Now, the one challenge there is you've got to wear them more than 12 hours to get that full 71% reduction. But it's pretty phenomenal for a non-invasive, non-surgical thing to actually reduce us by that 70%. Now, understand that currently there is no treatment we can do that stops myopia progression completely in the tracks. We have tried lots of other things, and the Stellest lens actually right now is the best tool in our tool belt to slow it down. Some of the other things that we have tried orthokeratology. Basically, it's a lens that reshapes the cornea, and it reduced the progression by 50% over a 2-year time frame, which was pretty phenomenal, pretty amazing. Now, there were challenges with the orthokeratology, the Ortho-K lenses. One is you had very strict and limited patient base. 2, it was extremely uncomfortable. I wore the lens for about a year. It's extremely uncomfortable. And then the third thing is lots of infections for these kiddos because of the way that they wear that lens. There's a lot of keratitis, a lot of inflammation going on that we were running into and seeing. The second thing is there are contact lenses out there. Multifocal contact lenses have been out there to try to help out, and they didn't do awful. They just slowed it by about 30%. And so 30% again is better than nothing, but it's not as great as what that Stellest lens is doing. Now, We also tried atropine drops. Atropine drops basically is a dilation drop. We would do a very low dose. You would do it at nighttime for about a 3-month timeline is how long you would do it. And research showed that it decreased it by about 60%. That's typically the treatment that I've been using for the last several years on my patients. Whenever I see those patients that I'm worried about, I usually talk to them about that atropine. But now I have the Stellest lens that I'm actually talking a lot to patients about. And so it's a big win because it's less invasive, less problematic, and by golly, it's better. 70% is better than 60%. Not massive, but it still is better. So who is a good patient for the Stellest lens? So we're really looking for 8 to 14 years of age. We can drift all the way down to about 3 to 14, but above 14, it doesn't seem to have a whole lot of real benefits. But that 8 to 14 is really the prime age range. If we have a large change, a 75 cent, a full diopter change in a year's time frame, we definitely need to discuss the Stellest lens. If it's someone that can't wear contact lenses, that's a big win. If they're in urban settings, the more urban we live, the more likely this is to be beneficial, the higher the educational pressure is. So if we're spending a lot more time reading, a lot more time doing math, a lot more time on the computer, if we're pushing ourselves a lot more academically, then it's probably a good thing as well. If both of our parents are nearsighted, something we need to consider is that Stellest lens. Who is it not good for? Who do I not recommend that get that Stellest lens? So again, if we're farsighted, I'm not going to talk to you about it. If we are 18 years old, 21 years old, it's not really going to gain us a lot of ground according to current research. Now, research may change what I'm saying today, but according to current research, it really doesn't have a big change there if we're a little bit older. If we have more than a diopter and a half of astigmatism, doesn't really gain us a lot of ground if they have a lot of astigmatism. And so if we've got a lot of astigmatism, we avoid those patients as well. So what is it that I tell parents to do? I encourage us to look at the cost of it. Whenever I compare the cost between the contact lenses, the atropine, the Stellest lens, price-wise, they're all fairly similar actually. There's not a big price point difference on those three right now. Now, orthokeratology is a different beast. It is a whole lot more expensive than these options, but from a cost standpoint, those three are fairly similar with each other. Stellest isn't a bad thing. The big drivers, are we gonna wear them 12 hours or more a day? That's a big one. There are follow-up visits. So I do wanna see the patient back in about 2 weeks, remind them that they're gonna wear that lens about 12 hours a day, make sure it's fitting on their face properly. And then I do wanna see them back in 6 months to see, are we having any progression or not yet? At that 6-month mark, I'm hoping for no change, worst case scenario, maybe a quarter change, but ideally we're getting no change at that 6-month visit. So my final verdict after trying it out on a handful of patients is it's not a bad thing. I really thought cosmetically that look of that lens would be an issue. I really thought it would irritate patients having that kind of glare at night coming off, but the patients that I've had in the lens so far, they haven't really had those complaints about it. My big concerns are going away on that front. So here's a few bonus questions that I wanted to add at the end that I'm getting from patients and parents mainly about myopia. So the first question is, does screen time make myopia worse? The jury's out on that right now, but a lot of the data is actually leaning towards it probably is going to increase the nearsightedness in the population. Just that higher demand on being up close, just in general. It's not that computers are bad. Next question I get is, can adults get the Stellest lens? Is that recommended for adults? And like I said, no, we don't need to mess with that. If we're already over the age of 14, it's probably not a big win for us to go into that Stellest lens. Do kids notice the lenslets? Not currently. The handful that I've put in haven't described being able to see them or really notice them or that they bother them. It almost feels like a scratch on a pair of glasses, but it's far enough outside of your normal view that it really doesn't seem to affect them or bother them at all. Does insurance cover it? That's a big one I get from parents. So occasionally it will, not all insurances do. Some of them do, but some of them don't. I'm hoping that as we move on, all of them will start to cover it. But right now it's a hit or miss. You really have to play around with that insurance provider to find out. Can you combine it with atropine? I love that question. Can you basically piggyback each other on top of each other? And research has said, yeah, we actually can combine them and we get a little bit of an additive effect. And so if at that 6-month mark, I have a patient that is still progressing with myopia, I will talk about adding atropine to the mix as well to see if we can't get that additive effect and really slow it down and stop it.